presenter is going to.
Good afternoon, everyone. I'm Dr. Monica. Today, my case study is on photorefractive keratectomy compared between two groups of low to moderate myopes versus high myopia. Coming to the procedure, photorefractive keratectomy is a photoablation procedure in which ultraviolet beam generated by 193 nanometers of argon fluoride excimer laser is irradiated to the corneal stroma after the epithelial removal to reshape the anterior corneal stroma to correct emmetropia. The newest generation wavelength 500 Hz high frequency excimer laser is safe and excellent, effectively treat high myopia with LASIK. So my aims and objectives. My primary objective is to compare visual outcomes of photorefractive keratectomy in low to moderate versus high myopes. Secondary objectives to compare postoperative complications in low to moderate versus high myopes and to compare the advantage of PRK over the other refractive surgeries. Material and methods. This is a retrospective comparative study was conducted for 1 year. All the patients were informed with written consent. Inclusion criteria: age greater than 21 years and stable refractive error not greater than 0.5 diopter change for not less than 6 months, and myopia with spherical power ranging from minus 0.5 diopters to 10 diopters, and astigmatism of minus 4 diopters were taken into the criteria. Exclusion: age less than 20 years, spherical power greater than 12 diopters, and ectatic disorders, no systemic or autoimmune disorders and ocular morbidities and severe dry eye were excluded. Preoperative evaluation protocol: uncorrected visual acuity, manifest and cycloplegic refraction, corneal topography by Sirius was done, and slit lamp, intraocular IOP measurement, fundus examination, and we have taken any history of contact lens usage for the past 6 months. Sample size was calculated by using a paired t-test. So postoperative regimen: postoperative medications were 0.5% moxifloxacin hourly for 3 days, then 4 times per day for 2 weeks. After that, patient was asked to stop the antibiotics, followed by 1% prednisolone acetate suspension 6 times per day for 3 days, then 4 times per day for 4 weeks. Subsequently, patient is shifted to 0.1% fluoromethalone 4 times per day for 3 months. Along with that, copious amounts of lubricants and oral analgesics were prescribed. Bandage contact lens were removed depending upon the epithelialization. Follow-up: patient was followed up on day 1 and 3, 7, and 1 month, 3 months, and 12 months post-operatively. The following things are assessed: uncorrected distant visual acuity and corrected distant visual acuity, slit lamp examination, and post-operative mean refractive spherical equivalent, corneal topography, and IOP. Measurements were taken at 1, 3rd, and 12 months respectively, and dilated fundoscopy was performed at 3rd and 12 months. Results: a total of 224 eyes of post-PRK were reviewed. Of them, 48 eyes was high myopes and 176 eyes were low to moderate myopes. Of the 66 were male and 46 were female. So this is the post-operative data. The efficacy index at 12 months post-operative surgery was not significantly different between the two groups. And predictability: we didn't notice a much predictable insignificant between the two groups. It was at the end of 12 months, we have noticed an MRSE of within 1 diopter at the end of 12 months. Stability: there is no much difference between the stability between the two groups. Safety index: at 12 months post-operative PRK, no one lost a more than 2 lines of Snellen's corrected distance visual acuity, and there is no insignificant between the two groups. Post-operative complications: patients who were with high myopes, only few patients among the 48 days, three patients experienced night vision symptoms like glare and halos, which was decreased by the end of 12 months. Corneal haziness and dry eye were not much significantly noted in two groups. Discussion: this study demonstrated that 12 months outcome of high myopic correction by PRK was safe and effective and safe compared with those of low to moderate. The efficacy index and safety index of PRK was excellent for both groups. Our analysis of 12 months outcome of high myopic PRK with wavelength EX 500 excimer laser resulted in excellent UDVA and low rate of complications. So most of the patients previously used to experience some amount of ectasia. With the recent wavelength X 500 laser, there is a decreased chances of ectasia, and moreover we are using a 0.02% of mitomycin by usually 10 seconds per diopter, not greater than for 40 seconds. So post-operative glare and halos were also decreased, along with the post-operative haze is also decreased. Advantages compared to LASIK: with recent PRK technique, haze is relatively less due to the use of
Time is up, please.
mitomycin C compared to phakic IOLs, if the patient anterior chamber depth is inadequate, we can go for the PRK. So my limitations of the study is contrast sensitivity and higher order aberrations were not assessed. However, all myopic patients were satisfied with the surgical results. These are my references. Thank you.
How many patients did you see haze?
Sir, in high myopes, only 4 patients has little haze, sir, where the patients recovered by 3 months, sir. We have accelerated the dose of steroids, sir.
What is the reason why you used predacetate for the first 4 weeks? Because
In order to subside the inflammation, sir, and to decrease the haze.
we've done thousands of cases of PRK and we never used predacetate. Loteprednol should be more than sufficient. It's important that you use the steroid for a longer time as compared to conventional LASIK. But predacetate in the initial period, especially when the epithelium is off, should be considered a higher risk. And also for 4 weeks, I don't recommend it.
Okay, sir.
The third thing is, what did you do differently as compared to low myopes? Normally, we notice that more than 6 diopters, unless you did something different to prevent haze, or it was a common procedure. How do you explain that?
Sir, we have increased the duration of mitomycin C, sir, application. Usually it is around 10 to 20 seconds. For high, when it is greater than 6 diopters, we have applied the mitomycin C for 40 seconds, sir.
No, you mentioned 10 seconds per diopter.
Yes,
so
madam,
for
but
about
it's
4
not
diopter, it's going to be 40.
But it's not more than 40 seconds, madam,
so
overall.
even 10 diopter is going to be 40. So you have not made it any different as such,
Okay.
isn't it? That's what I'm trying to tell.
Okay.
And what type of PRK was it? Was it a trans or a
No, madam.
the
Like
routine?
Few we have done trans PRK where the results weren't that good, so we didn't
Trans
include
didn't give you good results?
good results, madam.
Meaning to say the post-op visual recovery?
Yes, ma'am.
Okay.
And little bit of haze is also experienced by the patients, madam. That's why we stopped doing trans PRKs.
That's one thing. Second thing, you didn't mention anything about the Pachy cutoff. What was your Pachy range for, even for 10 diopters you are going for a PRK. So what was the Pachy that was acceptable for you?
400 microns, madam.
You mean residual stromal wear?
Yes, ma'am.
That would be 300 probably, 300 plus another.
I would say 350 probably.
Yeah.
Post
350, 400 would be little, okay.
Sir?
No cases were there in post-op glaucoma?
No, sir. We have
Because
not
you
noticed.
used prednisolone, no?
Yes, sir. Along with the, if and some patients we have started on AGMs also, sir, simultaneously. If we are using steroid like prednisolone acetate for longer duration, we have put on timolol eye drops, sir.
Without measuring? Or
We have measured it, sir. Upon that, we have
without
added to
measuring, you
prevent
should not.
glaucoma.
No, something would have, prompted you to use that. Probably you would have seen a myopic reading on the post-op AR or something, or if it was a very high myop and a borderline cornea, then you are suspecting your NCT is a routine, isn't it? You
Yes,
take an
yes,
NCT.
ma'am.
So based on that, you would have probably started off. Or was it a routine to start for high myopes and anti-glaucoma?
No, nothing like that, madam. After noting the NCT, if we feel that there is a bit high end, then we are starting it and asking the patient to follow up within 15 days or 1 month, madam.
What is the duration of your steroid therapy?
Sir, steroids, sir.
For low myopes and high myopes?
Low
Is
myopes,
same or?
like no, sir. For first 2 weeks, we have used 1% prednisolone acetate, sir. 4 times. After that, we have shifted to fluoromethalone, sir. For high myopes, we have used prednisolone.
Fluoromethalone, how long you are given?
We have given for a period of 2 months, sir.
For low myopes?
Yes, sir.
For high myopes?
High myopes, first we have given for 1 month of prednisolone acetate, we have given 4 times per.
Too
Even
toxic.
for cataract, we think twice. I'm surprised.
I
Anyway.
think the important thing for you to remember is more than anything else to prevent haze
Yes, sir.
is to see that there is compliance regarding the treatment. First of all, steroids should never be missed.
Okay.
The second
yes,
thing
sir.
is I'll always ask them to wear a UV protective goggles for the first 6 months.
Okay, sir.
Third thing, I don't know its usefulness, but using chilled BSS during the time of washing may be to some extent useful in preventing the haze. I feel that mitomycin not more than 1 minute in any case. should
Yeah.
be used. Maybe for very low powers you would use for a lesser time, but not more than 1 minute.
Yes, sir. Even if it is greater than 6 diopters, the maximum amount of time we have used is 40 seconds only, sir.
Yeah. Not to this thing, just out of curiosity, did you do a post, what was your follow-up?
12 months, ma'am.
12 months. So have you repeated your pentacam after that to see for those high myopes, how has their
Yeah,
recovery?
yes, I have done, madam. So
Huh.
for 6 months and 12 months, I have repeated, madam.
So you find it
And
good?
Yes, ma'am.
one more thing is you mentioned astigmatism of 4 diopters.
Yes, sir.
I too believe that PRK all acts equally well for higher degrees of astigmatism, but there is some controversy. Did you get any cases of regression,
No,
especially
sir.
when you are using, or a hyperopic shift when you were doing higher degrees of astigmatism
No,
with
sir. I
PRK?
haven't noted
Because many of the
anything.
surgeons, refractive surgeons, I have noticed is they don't prefer to correct higher degrees of astigmatism with PRK. They prefer a femtolasic rather than a. But I personally prefer, because of the risk of ectasia, whatever it is, many times in high astigmatic cases, there will be some points which you miss on topography and ultimately they come out. So I personally prefer that PRK is a safer procedure for higher astigmatic patients, pure astigmatism. But did you, in your case, get any hyperopic shift or
No,
regression
no,
in
sir.
such case?
Sir? Sorry, sir.
Maximum ablation, how much you ablated for high myopes?
60 to 80 microns, sir.
No, highest 60, 70, 100. Because you said you are telling